Good afternoon, everyone, and welcome to this one-day symposium fluid around the globe. And this is the second session, and we have three lectures in this. First of all, for the first lecture, I would like to invite Professor Manu Malbrain, who is the president of International Fluid Academy. He also works as in the Department of Internal Medicine Intensive Care CMO Medaman. He's a professor of critical care research in the Department of Anesthesia and Intensive Therapy in the Medical University of Lublin. He's the founder and president and treasurer of the World Abdominal Compartmental Society. He has around more than 300 publications in his name with H index of more than 82. One of the luminaries in this field of the fluid. He's one of the main authors of the very successful open access book, Rational Use of Fluids, which has been downloaded more than 1 million times. So welcome, Professor Malbrain. Now I'll ask you to share the screen for your talk, which is on the myths, 10 myths about the fluid. Welcome, Dr. Malbrain.
Okay, thank you so much for the introduction and the invitation. I think it's going to be a very interesting sessions. What I will talk about is some myths when it comes to fluid management and fluid therapy. And I think later on we'll have a lecture by Prajant and Tapesh in this session. So these are my conflicts of interest. I'm consulting for different companies for the topic of this course. I'm consulting for Baxter and Getinge. So let's kick off with an introduction on FAS, fluid accumulation syndrome. And as the word it says, it's a syndrome. It's not a disease. It can occur within many conditions and disease states. Yet many of our colleagues don't pay proper attention to fluid accumulation. Let me illustrate with this typical case of abdominal sepsis, perforated viscous, comes in the ICU, blood pressure is low, urine output is low, CVP is low, maybe passive leg raising is positive. So at the end of the day, the patient may have received quite a lot of saline fluid boluses. Why? Because it's kind of a reflex. When anything goes wrong, we believe that fluids are beneficial. On day 2, we see the abdomen is distended. Also, one of my favorites is intra-abdominal hypertension, and kidney function is deteriorating. By day 4, urine output halts and there is a positive cumulative fluid balance and the patient is on CVVH. And on day 7, there is sudden cardiac arrest because of secondary abdominal compartment syndrome due to acute mesenteric ischemia. So I think abdominal hypertension may be a killer in the ICU, but the question here is, did you do everything to prevent fluid accumulation syndrome? And are we shifting our mindset and thinking about fluid stewardship? So it's all about breaking some bad habits, and that's why almost 13 years ago we founded the International Fluid Academy, and the mission statement is to promote research, to foster education on fluid management, and thereby hopefully improve survival of critical patients. So education, research, and collaboration, and I think that's exactly what we are doing today by bringing together healthcare providers from all over, in this case from India. So we could think that junior doctors already receive enough of training, but when I was a medical student, I exactly received 0.0 hours of education and training on fluid management. And when we conducted this international survey on the knowledge of fluids amongst more than 1,000 healthcare providers, the average score was 46%. So we did not pass the test, and probably you would not either. So as already introduced, I'm very proud and happy that this open access book is now, I just checked, been downloaded 1,100,000 times, which tells me two things. One, when it's for free, people like it because it's readily available. But two, it tells me that there is an eagerness and a need to learn more about fluid management and fluid stewardship. So the 10 myths I will try to bust, I will try to fix them into the 10D framework on the definitions, the diagnosis, distribution of fluid. Every fluid is lost to the interstitium. And then the 4 Ds that we know from antibiotic stewardship. So it's about the drug, the dose, the duration of treatment, de-escalation, documentation. We need to look what we are doing, diligence, which is a beautiful English word for carefulness. We should treat fluids as drugs. And the discussion is all about leadership, because when we are giving saline to our patients and we must shift the mindset towards balanced solutions, this is about change management and leadership. So when you have D1 to D10, you multiply, you have D to the power of 10, and this is what I would call fluid stewardship. So the first chapter in the book is about definitions, and it gives a full list, and I invite everyone to download and have a look at it, as the fluid status is very important. But as topic, there are lots of myths and misunderstandings. We all know the fluid balance calculated by the nurses, the cumulative fluid balance. Fluid overload used to be defined as an all or none phenomenon. So you either have it or you don't. And I think this myth is busted, as we are now looking into fluid accumulation rather than fluid overload. So when we are overloading your patient, leading to hypervolemia, hyperhydration, peripheral edema, giving fluids by hydrostatic forces will result in peripheral edema. But the opposite is not true. So it's not because you're edematous that you're also hypervolemic. So that's why Jean-Louis Vincent suggested to avoid the term fluid overload. And everything you need to know about this topic can be found in this other open access paper. And just recently, a comprehensive review was published on fluid accumulation syndrome. So fluid accumulation, either you calculate the actual weight or the change in weight or the cumulative fluid balance in relation to the admission body weight or the usual body weight known of the patient. While most of the fluids are intracellular, when we talk about fluid accumulation, we are referring to extracellular water increases. Of course, when we're talking about hypervolemia, we're talking about intravascular fluids that increase. So there are a lot of misconceptions around these terms, and the new definition for fluid accumulation syndrome is any percentage increase with a negative impact on organ failure function. So the visual graphic of the recent paper is shown here, and it nicely summarized the pathophysiology, diagnosis, prevention, and treatment of this condition. Which brings me to D2, which is about the diagnosis, as we know that hypovolemia is bad because you have hypoperfusion, convective problems, but hypervolemia may even be worse as you have diffusion problems. Oxygen can't get to the tissue, as we've seen in the case at the beginning. And that's why the prediction of fluid responsiveness is key. And in this paper with Xavier Monet, Michael Pinksy, we give a list of different fluid responsive tests, each with a separate threshold. But one point I want to make clear is that there is now a new concept, fluid tolerance, the maximum amount of fluids that you can give without causing harm. And there is this VEXA score that has been proposed by the group of Philip Rolla. And they found that even patients who are fluid responsive can have venous congestion and a VEXA grade 1 and 2. So this brings me to some of the myths, like not all septic patients are hypovolemic. They may just be vasoplegic at the very beginning. The presence of peripheral edema does not mean that diuretics are needed. And a low preload does not mean either that fluids need to be given. Just because you're fluid responsive, you don't need to be given fluids, as fluid responsiveness is the natural state. We are all fluid responsive as I speak. And the presence of fluid responsive does not mean that you're hypovolemic or that you're fluid tolerant. So these are all different concepts that can exist independently. So D3 is about the distribution, and remember that every fluid will be lost to the interstitium after administration. So it's a myth that when we are administering intravenous fluids, that we will have a volume expansion effect. As we know, the body is mainly fluid in character, fluids being intracellular mainly, and from the extracellular, 1/4 constitutes the intravascular fluid. So when we are giving an isotonic solution, after 1 hour, giving 1 liter, about 25% will remain intravascular. So it's a misconception that these fluids will remain for a longer period of time. And when you're giving a fluid bolus, already after half an hour, the beneficial effect on cardiac output is fading away. On the contrary, if you give a hypotonic solution, this is good for cellular rehydration. Only 8% will remain intravascular. So D4, as I told you, is about the drug. Fluids are drugs. And there are only 4 indications to give fluids: for resuscitation, to save lives; routine maintenance, to cover the daily needs of sodium, water, glucose; replacement, then we should give the fluid that mimics the fluid that is lost. So if the patient loses blood, give blood. If the patient loses saline, give saline. But that's only the case when there are vomiting and upper GI tract losses. Nutrition, to cover the caloric needs. But a 5th reason why fluids go into the patient is to dissolve other drugs in, like antibiotics, painkillers, antacids. And remember, we have a redistribution of the fluid, so we have to reassess volemia and fluid responsiveness. Now, in this study on 15,000 patients, we looked where the fluids came from. 3% are blood products and only 6% are fluids for resuscitation. So this is all the big fluid trials, SPLIT, CHEST, SUCCESS, SMART, you name it, but it's only 6% of the total amount of fluids. Whereas maintenance replacement, about 1/4, nutrition 33, and look at this, fluid creep is 33%. So fluids that are given unintentionally, not to give fluids, but to give antibiotics and other drugs. So resuscitation type of fluids is only a minor part of the fluids that we administer. And the discussion recently went on saline versus balanced crystalloids. So the difference is in the strong iron difference, as there is nothing normal about saline with 154 millimole of sodium and chloride. So we should give buffered solutions to exert a strong iron difference effect. And if we look at the systematic review of the recent big fluid trials, going from PLUS, Basics, SPLIT, SMART, and SALT, covering about 34,000 patients, there is a tendency that balanced solutions will reduce mortality and major adverse kidney events, especially if you only give balanced during the whole trajectory of the patient from ER to ICU, and especially in sepsis, burns, DKA, but not in traumatic brain injury. So maybe it's about time to stop abnormal saline, because there's a lot of detrimental impacts. And even 1 bag of saline may contain 3.5 grams of free sodium, which is more than the daily requirements of 2.3. Dose is important, as everything can be poisonous if you give enough of it. Even free water poisoning exists if you drink too much of water. We know from antibiotics that there is the pharmacokinetics, pharmacodynamics, and also for fluids, if you give too much or too little. And we must be aware that as long as you're infusing, there is a volume expansion effect. And this is especially the case in patients with shock, as excretion and distribution is low. So crystalloids and colloids may have a similar volume expansion effect. So D6 is about duration. And not as I showed in the case, it's not because blood pressure is low, urine output, CVP. We should not treat the numbers, but only give fluids when the patient needs it. For instance, when he's in shock. De-escalation is lowering the speed and the amount of fluids, and this brings me to the ROSE conceptual model, where we have resuscitation phase, optimization, stabilization, evacuation. So resuscitation is about patient rescue, optimization, organ rescue, stabilization, support of the organs, and evacuation is about recovery of organ function. So it's very important to pick your targets, triggers, and safety limits in order to reach the goal, which would be to avoid fluid accumulation syndrome or a global increased permeability syndrome. Why is that? Because fluid overload at the outside will mirror fluid accumulation at each organ system: venous hypertension, venous congestion, and organ failure. So when it comes down to fluids, and the myths that need to be busted is it's all about the right fluid, dose, rate, duration, indication, patient at the right timing. So to wrap things up, ladies and gentlemen, and let's give an overview of, I think it's not 10 myths, but it's a bit more. So I showed you that the training and the knowledge on IV fluids is not good. Junior doctors are not aware of different indications and compositions of fluid therapy, and we need to support education and training. Fluid overload is not a good term. It's not an all or nothing phenomenon. So we should talk about fluid accumulation in association with organ failure related to fluid accumulation. Remember that not all septic patients are hypovolemic. They may just be vasoplegic. So maybe by giving noradrenaline early, we may recruit unstressed stress volume from the unstressed. I showed you that the patient with peripheral edema may be vascularly hypovolemic, fluid responsive, so diuretics are not always needed. And when preload or filling status is low, it does not mean that fluids need to be given. Also, the fact that you're fluid responsive does not mean that fluids are needed, because we are all fluid responsive as I speak. And the fact that a patient is fluid responsive, on the other hand, doesn't mean that he is hypovolemic, nor does it mean that he's fluid tolerant. So these terms like preload, fluid responsiveness, fluid tolerance are separate terms that can be combined in different ways. I showed you that intravenous fluids will not remain intravenously. They will leak out, and for crystalloids, after 1 hour, about 75% will be interstitially. And the major indication for fluids that we give to our patient is not for resuscitation, although most of the big fluid trials are dealing with those. It's rather for fluid creep and fluid replacement, and this we must be aware. One bag of, I would call it abnormal saline, is not without risk. I told you 1 bag is already too much salt, and even for healthy kidneys, it will take days to get rid of the excess sodium. Don't wait for full-blown fluid accumulation syndrome to start thinking of de-escalation. Start de-escalation whenever possible, when shock has resolved, lactate is normal, tissue perfusion is normal, and when the patient can have an oral intake. So colloids are not superior to crystalloids in a shock patient. Studies by Robert Hahn, and I will be talking about this, show that as long as a shock state persists, excretion and distribution is low and slow. Saline is not better than balanced in AKI with increased potassium. Nephrologists used to give saline because they think there is no potassium, so it's safe. No, it's not. Giving saline with a strong ion difference of 0 will actually increase potassium levels. The fact that lactate is increased does not always mean that fluids are needed. So there are other causes of lactate that may not respond to fluid treatment. Continuous CVP, so we are shifting away from the CVP. I didn't discuss much of this, but I think that CVP is a very interesting parameter. When it's low, okay, it tells you probably preload is low. But when it's high, it may be important in the setting of venous congestion, venous hypertension. Human albumin, well, we are waiting for the Albios 2 trials to be published. But I think albumin may have other properties like anti-inflammatory and so forth, and may have an indication, the hypertonic one, in later phases for de-resuscitation and shifting fluids from the interstitial to the intravascular space. Septic patients do not all need their 30 ml per kg. Some may need more and others may need less. Fluid balance does not need to be 0 as soon as possible, only when shock has resolved. And the fluids that are accumulated are kind of a biomarker for critical illness. So the more fluids that the patient keeps on board, probably the sicker he is. And maybe we need to do a better source control. Remember that all the fluids come in plastic bags, and now we're talking about sustainability and getting rid of all these plastic waste. So the advice here is use the smallest bag to administer the fluid that the patient needs. And also patients with cardiac failure and renal failure, where we are a bit afraid to give fluids, they can also have sepsis and be hypovolemic. So fluids should also not be avoided in those patients. And then the question is, should we go for advanced monitoring like Swan-Ganz or PICO? I think there are other ways, like looking at peripheral saturation, the platelet variability index, PPV values, the passive lag raising. So if you don't have an advanced monitor, it does not mean that we are lost. So this would be my 50 cents. I hope I convinced you that IV fluids are not just innocent bags of water. They are not. They are real drugs, and they should be treated accordingly. And I just would like to announce...
My name is Mia,
the
and
Fluid
I have
Champion
something
course.
interesting to show you. The International Fluid Academy is working on a Fluid Champion course. Do you want to ride along on this adventure? Let's have a look and dive in the world of fluid management. At our new developed members portal, you can find almost everything about fluid management and fluid stewardship. In our community, you can find discussion forums, a calendar with a...
So the basic course is online, and it's free for everyone to sign up. Thank you for your attention.
Okay. Thank you, Professor Malbrin, for this excellent explanation of all the myths that you have regarding fluid therapy. We'd like to ask the audience if they have any question, they can put in the chat box. Till we have any question, I have one thing to ask Professor Malbrin. First thing, what you said is perfectly correct. We from the residency to each conference and each seminar or CME, we talk about the fluids, what are the advantage and what are the disadvantage. But when you come to practically use it, we have been found that in many instances it is not used as a drug. In a ICU or a intensive care or a emergency department, we don't use anything as casually as the fluids that we use in drugs or any other intervention. So I just want to ask, what do you think? What is the reason behind this? That although it is talked about a lot, when into clinical practice, it is less practiced.
Yeah, no, I think it's perception, and it's in the mindset that probably one bag of fluids is not harmful. If you look at the fluid trials comparing saline versus balanced, randomization is usually after 24 hours, and the study drug given is usually 2 liters or something within the first week. So probably the conclusion is that it's not making much of a difference, and most of the individual studies don't show any hard outcome difference. But I think it's wrong. It's a misconception, because even one bag of saline carries a lot of sodium. And after 1 week, we've done these studies in healthy volunteers and critically ill. You have a positive sodium balance, which will lead to a positive fluid balance. And even for healthy people, it takes a lot of time to get rid of the excess sodium. So it's all about change management, and this takes time because people don't want to change. And the only person to drive this change, in my view, could be the clinical pharmacist, because he actually knows the fluids that are leaving the pharmacy and have been administered in the ER, ICU, operating theater. Individual doctors will say, I do correct, I don't give saline, I give balanced when needed, and so forth. But that's all about the change that fluid stewardship wants to implement, and the Fluid Academy would like to support hospitals to become a center of excellence. So this is a warm call to join, do the course, and then let's see how to implement it in the hospital.
Okay, thank you, Professor Malbrin. One more thing you talk about, that as the sepsis is first of all, it's a state of vasoplegia rather than a hypovolemia. So, and one of your comment was maybe in future we can use adrenaline in the initial stages to bring back the fluid to the intravascular compartment. So, is there any trials, or is there any study you are working on, or use of any other drugs in the initial stage of sepsis for the vasoplegia management rather than giving for fluids?
Yes, there are studies showing that, in fact, the administration of norepinephrine may be synergistic to fluid administration. So rather than waiting for 30 ml per kg fluids to start your vasopressors, I think giving them early will result in the fact that you need less fluids to achieve the same effect on cardiac output. So yes, I fully agree. And the fact that you don't have a CVC does not prevent you from giving it. You can use a peripheral line for initial low dose of norepinephrine. The other vasopressor drugs like vasopressin, I think we need more data as to understand what is the exact dose and the exact timing of the secondary vasopressor in relation to norepinephrine. But yes, please, in case of vasoplegia, start early. Of course not if there is another cause like obstructive shock or cardiogenic shock or...
So, any question? There is a question, Professor Malbrin. So the question is there any role for fluids to adsorb?
Yes, of course, absolutely. So I invite Ketan Kerhirwar to join the Fluid Academy, follow the Basic Fluid Champion course, and try to identify one doctor, one nurse, one pharmacist, one dietitian in your hospital to roll out fluid stewardship. And it's all about education and training, but you have to look first in your unit, what is the actual state? And you will be amazed to see that probably there is still a lot of saline given, a lot of maintenance that's not needed, and per patient and per day, we're giving too much fluids.
Yes. Any other questions you can put in the chat? Yes, there is another question by Dr. Geeta Nath. The question is there a maximum limit for norepinephrine concentration for peripheral administration?
Yeah, is a good point. Of course, it depends on the individual case and the status of the veins, but 0.1 usually is not a problem, and even you could go to 0.25 for not for hours, but for a short period of time to buy you some time, stabilize, and then get your central line.
Okay. Another thing I want to discuss, Professor Malbrin, is that you talk about the fluid responsiveness and fluid tolerance. So in the last decade, the fluid responsiveness, we have talked many ways to find out whether the patient is fluid responsive or not. But with the concept of fluid tolerance, we find out that although the patient is responsive, what the fluid tolerance level has already crossed. So ideally, in an ideal scenario, the responsive point and the tolerance point may be the same, but in practically, we hardly find anything like that. So
Yes.
do you suspect we'll always look for the tolerance rather than the responsiveness, or responsiveness is useful or not?
Very good point, and is a topic for a lot of discussion and controversy. I have to point, I'm not a fan of inferior vena cava ultrasound and the VEXA score. The initial paper published by the group of Philip Rolla from Canada has been validated in cardiac surgery patients. So the studies that were done later on in mixed ICU sepsis did not show the same results. So that is the first. So I think it's a good idea conceptually to look at venous congestion and venous hypertension. But I showed you also that patients who are fluid responsive at the early stages of septic shock that need fluids, maybe in combination of pressors, may also already have congestion grade 1 and grade 2. So there is a lot of overlap. I think in the R phase of resuscitation, we're talking about minutes, hours. I don't think we need to wonder about fluid responsiveness. Fluids should be given. The importance comes later on, and then I'm talking rather than days, than on day 2, 3, where normally you have the tipping point of the evacuation. The presence of fluid unresponsiveness. So if you have a negative passive leg raising, that may be a good sign that the patient is ready for the resuscitation. So I would use it the other way around. because fluid responsiveness is the normal situation. So we need to go back to a state of fluid responsiveness. But when it comes to VEXUS score and congestion, I think we would need more monitoring tools. I like intra-abdominal hypertension. I like extravascular lung water, PVPI. You could do ultrasound, look at B lines. So not focus solely on VEXUS score because it needs more validation.
Okay, sir. Thank you. And there is another question from Dr. Ketan. He want to know if the positive fluid balance or daily weighing of the patient, which is more reliable.
Yeah, well, both are cumbersome. And there is nothing so difficult as having a correct daily fluid balance or a correct daily weight. So I would suggest do both, and they should go both in the same direction. There's an old paper from Denmark by Brandstrup, where they show that the positive fluid balance will lead to increase in body weight, and this will relate to more complications. So they are related, and there are many studies pointing the link between a positive cumulative fluid balance and adverse outcomes. Daily body weight is a bit more cumbersome, but if you do it systematically in the same way, it should be doable. Maybe other techniques like bioelectrical impedance analysis, looking at fluid body composition, looking at volume excess, could be interesting. But yeah, I would say do as much as possible as you can in the right way. But the thing I want to say is that it's not because you have a positive cumulative fluid balance that we need to de-resuscitate, okay? The patient may do fine, and most of the patient will go to a spontaneously polyuric phase, as we see with acute tubular necrosis when kidney function recovers. So if there is no fluid accumulation syndrome, just let it be and wait and see. Of course, if there is ongoing infection, inflammation, CRP, pulmonary edema, low oxygenation, then of course you must get rid of the excess fluids. Because de-resuscitation is also a treatment. It needs not to be too aggressive, too early, too fast. So you should only do it when it's needed, and the best thing is to avoid it. So de-escalation of fluids is even more important after the initial resuscitation phase. Stop as soon as possible.
Yes. Any other questions? So if not, I have one comment, Professor Malbrin. You talk about CVP, continuous CVP monitoring. I also strongly agree that with the modern era, many people have discarded CVP. So maybe a static reading, maybe discarded a continuous reading may have some data how the patient is behaving. Many people have shifted to IVC, which has the same limitation that of the CVP. Maybe in a emergency scenario or in a ED, where the patient comes, you don't have any lines, you can measure or have an idea by looking at the IVC. But discarding CVP totally in an intensive care setup may not be a good idea. It may have certain idea, or at least give some same idea that of the IVC.
Yeah, fully agree. And I would like to add, whatever you do in the ICU or the ER or the operating theater, do it as a challenge. And a challenge for me is that you look what is happening before, preload, fluid responsiveness, maybe the CVP at baseline. You do something, give the fluids, the butamine or norepinephrine, and you check again what is happening. So to have a dynamic evolution of your CVP. If it's 4, you give fluids, it's still 4, then you know you're on the steep part of the Frank Starling. If it's 4, you give fluids and it increases to 10, then you know, okay, let's stop here. But if you only have one isolated value, you will lose the dynamic power of a continuous monitoring tool. But that's for everything that you monitor. Look at it in a dynamic fashion. And CVP, well, in the early phase, when it's low, but it will never tell you when to stop. You can give fluids in a patient with sepsis, and CVP remains low, and you may already be at the right path. But when it's high in the initial phases, you don't know. because it may be high due to PEEP, due to intra-abdominal hypertension, and so forth. But at a later stage, when it's high, I think it's usually related to fluid accumulation and venous congestion.
Okay.
Or RV failure, which is also important.
So probably there is no more question, and Dr. Nasa is waiting. Lastly, one more comment. When do you start this de-resuscitation, and how do you do it?
So when to start de-resuscitation? Only when needed. So don't do anything if the patient is fine, is sitting in the chair, is reading the newspaper without oxygen. Let it be. Only think about it when there is fluid accumulation syndrome, when there is a global increased permeability syndrome, the Michelin man I showed you, when there is venous congestion. Okay, you can add up. When tissue perfusion is normal, so patient should not be shocked. When lactate is normal, because patient has been resuscitated, and when you have, let's say, a noradrenaline dose of maximum 0.3, you could de-resuscitate with some. So if this is the condition, then we do furosemide stress test, which is 1 milligram of furosemide as a bolus. You wait 2 hours. If urine output is 200, then patient passed the test and probably is ready for de-resuscitation. So you start with diuretics, maybe in combination with albumin, hyperoncotic. If albumin levels are low, we normalize them up to 30 grams per liter, like in the Albios study. And then you can have albumin with furosemide combination treatment of antibiotics. You can add some acetazolamide, indapamide, depending whether the sodium or the base deficit is altered. And if all that doesn't work and there is still fluid accumulation syndrome, then we escalate to mechanical removal with CVVH and ultrafiltration, maybe in combination with albumin. Hypertonic. It usually works, but takes time. It takes about 1 week to get rid of 7 liters, just slowly. So the best thing is not to wait until the patient has gained 7 liters, but to de-escalate as soon as possible.
Thank you, Dr. Professor Malbrain. So if there is no more questions, so it's an excellent talk, an excellent discussion, Professor Malbrain. We'll move to the next talk by Professor Prasant Nasa. So